Chairman of the Medical Advisory Committee of the University of Ilorin Teaching Hospital, Dr. Odega, and we'll be inviting him right away to give the opening prayer. We welcome our guest speakers and every participant. We recognize directors of pharmaceutical services, deputy directors, fellows of the Pharmaceutical Society of Nigeria, fellows of the College of Postgraduate College of Pharmacy, professors, members of PSN, AHAP, and CPAN. We welcome the chairman.
Oh, thank you very much. I'm Dr. Odega L.O., the Director of Medical Services and Training, University of Ilorin Teaching Hospital. I'm indeed very pleased to be part of this clinical roundtable with specialist pharmacists from across the world. I want to congratulate our Department of Pharmacy here in the University of Ilorin Teaching Hospital. I'm not really very surprised. I've been part of quite a lot of your programs. And I must say that the teaching hospital is very proud of the crop of people we have in that department. We are very proud of you. So I use this opportunity to welcome each and every one of us to this clinical roundtable. I understand that there are people from across the continents in diaspora, and we're really pleased to be having this mix. And I know that at the end of this roundtable, we would have gained quite a lot here on how to manage our services here and improve. So I thank you once again. And on behalf of the Chief Medical Director of the hospital, I welcome you to this clinical roundtable. Thank you very much and welcome.
Thank you, sir. I would like to just give a few seconds to Professor Femi Oyewo.
I'm blessed to be at this roundtable meeting with them, and I want to put it on record that University of Ilorin Department, the Department of Pharmacy, has indeed showcased excellence in clinical presentations, bringing in people from all over the globe on issues that are so important and necessary to all, especially during the COVID-19 period and the lockdown. I appreciate the department, and I want to ask you to keep it up. The panelists, I've seen the panelists, and that's one of the reasons why I said I must be there. I have one or two friends there. Teresa Pound is there, and it's always a delight to listen to her and all the others. So I know we're going to have a wonderful time, and I'm really looking forward to that. I believe at the end, we in this part of the world would have gained a lot to move our practice forward wherever we are practicing. Thank you very much for having me. God bless you. I'm incidentally the chairman, board of fellows of the Pharmaceutical Society of Nigeria. God bless you all.
Okay, thank you. So today we
thank you.
have
over to you, out and over.
Yeah, thanks. So we have a 5-member panel led by Dr. Teresa Pounds. Each member of the panel will have 10 minutes to give us a short presentation on what they do and how they get to what they are doing. And then after that, we have 10 minutes where we can rub minds, ask questions with them. Dr. Teresa Pounds is a clinical pharmacy manager and PGY1 Residency Director, West Star Atlanta Medical Center. She's an assistant dean for experiential education, South University School of Pharmacy, a clinical associate professor, Philadelphia College of Osteopathic Medicine School of Pharmacy, adjunct clinical assistant professor, Nwaesei University College of Pharmacy, and her areas of specialization is nutrition support. Dr. Teresa Pounds, you're welcome to take the podium.
Yeah, thank you so much. I hope everybody can hear me for that wonderful, wonderful introduction. Let me start by saying that it is always a pleasure to be part of such sessions. I wish we were able to be there in person, but this is still, it's still okay. So it's a pleasure. I had a chance to at least see some of my old friends. Dr. Yehu, we know where we go back. It's always good to give back to our country. So thank you again for the invitation. What I will do is I will briefly mention the names of the clinical specialists who are with me today. I will give them the opportunity to talk about what they do, just like we just mentioned. Then I will also make some time to kind of talk about what I do. So let me start. There's something that all of these specialists have in common that I hope that by now all of you will know. One thing they have in common is they have all been to Nigeria physically. Dr. Pamela Moyer, who is the first person I'm going to introduce, she's a clinical associate professor. Actually, it's Dr. Pamela Moye-Dickerson. When she was coming to Nigeria, she was Dr. Moyer. Now she's married and her name is Dickerson. She is a clinical associate professor, Mercer University School of Pharmacy, and she will also share with us what her areas of specialty is. What are some of the unique things she does as a specialist to, that really makes her stand out in that field. So welcome, Dr. Pamela Moye-Dickerson. Good to have you on board. Then the next person I would like to introduce is Dr. Uche Ndefo. Dr. Uche Ndefo also has been to Nigeria. She's a Nigerian like I am, has done a lot with me. These two individuals started with me from day one when we had a pharmacotherapy workshop in Benin. So she's professor, director of educational effectiveness at the Texas Southern University College of Pharmacy and Health Sciences. And her areas of specialization are, like I mentioned, educational effectiveness, drug information, and managed care. So welcome, Dr. Ndefo, to the panel. Then the next person I would like to introduce is Dr. Angela. Now, please, she may shoot me. I'm from Delta, and I should know how to say her last name. But if I kill it, please, excuse me. It's Nwaesei, okay? Yeah, so I hope I did okay. She used to be Dr. Angela Shobogun. That one I can say because I was raised in Lagos and I speak that language very well. Now, she is clinical associate professor, Mercer University College of Pharmacy. Her areas of specialization is internal medicine. So welcome again, Dr. Angela, to the group. Now, the last person, and not the least, that I would like to introduce is Dr. Ashish Advani. Again, he's a PharmD. He's doing some very unique things that I think we need to really listen to here that really shows you that specialists in areas of pharmacy, we can do some unique and innovative things. He is president and CEO of InfamD. This is a drug information, he's a drug information specialist and actually uses the whole of WellStar, which is my institution, organization actually, that I will be able to share with you guys in different areas. All the institutions in the WellStar organization use his services, and his areas of specialization is drug information. So again, I would like to welcome Dr. Ashish Advani for joining us to this panel. Now, I think now that I've done the general introduction, I think what I would suggest is let's go ahead and have Dr. Pamela Moye-Dickerson talk to us about what she does.
No, Dr. Pounds?
Yes.
You go first.
Oh, I should go first? Okay, all right. She wants me to go first.
Do you see your slide?
Now, yeah, I can see the slide. So let me start with me. Pamela Moye decides I should start first, which is okay. Actually, where did my story start? I'm a pharmacist, PharmD. I have two degrees. I have a Bachelor of Science in Pharmacy from Mercer University School of Pharmacy. Then also I have my Doctor of Pharmacy degree. So I have 2 degrees, bachelor's in pharmacy and doctor of pharmacy. I did my residency also at the institution. It used to be called Georgia Baptist. I did a general, then I specialized in a particular field of clinical pharmacy, which is nutrition support. But because I'm in nutrition support, I also have some critical care background. Pam, are you sharing the slides?
No, it stopped. Hold on one second. Sorry.
Excuse us for a minute. No, while she's trying to get that on, what I would like to share with you guys is what I do, what a typical day looks like for me. So right now, I am the clinical pharmacy manager. I'm also the residency, the PGY1 residency program director. And as mentioned earlier, I have some affiliations with certain pharmacy schools. So what I will do is talk to you guys about each of those. As a clinical pharmacy manager, what do I do? What I do is I support the director of pharmacy program when it comes to management, implementation of clinical pharmacy programs. I'm actually the one that is the liaison between pharmacy department and the medical staff. So a lot of the committees, I actually either coordinate the committees, run the committees, or I represent pharmacy department in that. For example, Antimicrobial Stewardship Committee is a multidisciplinary committee. That's a committee that looks at everything as it pertains to antimicrobial stewardship, ranging from policies, procedures, education, some drugs that we need to have on the formulary, and so on and so forth. I'm also on what we call the Pharmacy and Therapeutics Committee. This is the committee that looks at the drugs that need to be on the formulary, and I'm sure we have that too in Nigeria. So I'm a representative on that. So when it comes to now, my other title is I am the residency program director for PGY1. As you all know, PGY1, that means that's the generalist residency pharmacy program. That is actually where the resident will decide whether they want to just end up just doing 1 year residency and become what you call a generalist clinical pharmacist, or decide to move on for another year and specialize in the pharmacy. So I direct that program. We have accreditation with ASHP. I ensure that we have policies in place that addresses how we choose our candidates, how we interview for the candidates, what the curriculum looks like, the evaluation of the residents. Make sure that I have what we call preceptors, people which are actually teachers or instructors that really work with the residents and make sure that they have a good experience for the 1 year training program. So as a residency program director, that's what I do. Now, as a specialist in nutrition support, what do I do? I actually run what we call a metabolic support service. The metabolic support service is a multidisciplinary team. I have a dietitian who is on that team. I have a nurse who is on that team. I have a pharmacist who is on that team. And then I have residents. I actually have a medical intern who is on that team. I have a medical student who is on that team, pharmacy student who's on that team. And what we do on a daily basis is that we round on the patients who are receiving specialized nutrition support. Now, you may ask me, what is specialized nutrition support? That is nutrition that is either given via the tube, in that way you call it tube feeding, or nutrition that is given via IV, which is then called total parenteral nutrition. So this round is done daily, whereby we round on this patient, we make decisions in terms of, is the formulation that they're on appropriate? Are they metabolically stable? Should we make any electrolyte changes? Should we transition them from parenteral to enteral? And we manage all these patients. Manage them meaning we work with the doctors who consult us on this case to make sure we do that. So that's that. I think already on the other one, now that the slides is up, you guys can pretty much see what I mentioned earlier before the slides came up in terms of what I do as a clinical director, a clinical support for the director of pharmacy clinically. But one thing I'd like to mention that I think is unique, that maybe some of you are already doing is the fact that I have non-pharmacy students who are also precept, meaning that do rotations with me. I have doctors that do rotations with me. I also have medical students that do rotation with me. And I think this is one thing that is definitely unique that will continue to help us with that collaboration with the other disciplines. Because when they do rotation with me, then they get a chance to see what pharmacists actually do. So that when they are out somewhere practicing, the first thing they're going to ask is, who is the pharmacist on my team? Now, the other unique thing with my residency program is most residency programs are 100% under pharmacy, meaning it's strictly under pharmacy. Mine, because I'm in an institution that has other training programs for the doctors, I have affiliation with what we call our graduate medical education. So my residents get a chance to actually interact and collaborate with other disciplines, with the surgical residents, with the medical residents, and that again introduces that concept of that collaboration. So I think I would kind of like to stop here, and maybe at the end when you all have questions, I'll be able to address. And of course, as a specialist, I'm involved in research. So that's another thing we do. We collaborate together. We do research studies because, as you know, when you publish, that's how people get to know what you do, and that's how people get to know about your institution. Yeah. So Pam, I don't know if we can go back to the first slide, the one about my institution. I think I would like to discuss briefly Wellstar Atlanta Medical Center, which is where I work. I think it would be good for you guys to kind of have an idea of that. It's a 460-bed tertiary center hospital. It's a level 1 trauma hospital. We are very busy when it comes to trauma. And also a level 3 neonatal unit. I already mentioned that we have Department of Graduate Medical Education. And as you can see, the different programs they have for the physicians. And then you can see the pharmacy program. We have general surgery, the vascular surgery fellowship, internal medicine, family medicine, and then pharmacy is part of it. So that sends a very loud message. So it sends a message to say, we are all in this together. We're collaborating. Our residency program is there. So these residents, they start by knowing all about pharmacy. And when they finish their program and they go elsewhere, they have already been exposed to what pharmacists can do. And they will always ask, who is a pharmacist on my team, We also have medical services like Atlanta Center for Sleep Disorders, Atlanta Rehabilitation Center, Wellness Center. But the other point I would like to make is that we are part of a Wellstar healthcare system. Wellstar healthcare system has 11 institutions, and our institution is one of them. So I think I will stop right now and go so we can move on to to Dr. Pamela Moye-Dickerson to tell us, to spend like 10 minutes to tell us what she does in her area of specialty. Dr. Moye.
Okay. Hold on, I'm moving. So hello, everyone. Thank you for having me this afternoon. As Dr. Pound said, I'm Dr. Pamela Moye-Dickerson. I got my bachelor's degree in chemistry from the University of North Carolina at Greensboro, North Carolina. My PharmD at the University of Georgia in Athens, Georgia. I did a PGY1. Back when I did it, it was called Pharmacy Practice Residency, and at Duke University Medical Center in North Carolina. And I did a specialty residency in adult internal medicine at Virginia Commonwealth University Medical Center in Richmond, Virginia. Like Dr. Pounds, my practice site is Wellstar Atlanta Medical Center. So I will not go over that again, but I will describe what my service looks like and what a typical day looks like for myself and for my students. So I do round with the internal medicine service. We have 3 teaching teams. Dr. Pounds mentioned that we, the pharmacy residencies are part of the graduate medical education department. And so for the internal medicine is one of the medical residencies that we offer. So I round with that, one of those 3 teams, really 2 of those 3 teams. Because normally I will have 1 to 3 students on rounds with me, and I put them all on different teams. And generally our patient load is about 14 patients per team. So for example, last roadblock, I had 2 students, and one was with team B, one's with team C. And the students end up working the patients up and rounding with the physicians. And how the medical team is made up, we have 1 attending physician, and that changes every month or every 2 weeks, depending on who's on vacation. 1 attending pharmacist, and that will be me. And also what Dr. Pounds is doing, she wants to bring up her clinical pharmacists and have them round with internal medicine teaching team. So right now we're trying something new with Anna rounding with one of the pharmacists rounding with team A. I'm still covering teams B and C until the other pharmacist comes back from maternity leave, and then she's gonna be with team B and I will be with team C. So that way the teaching teams always have a pharmacist available. And then we'll work on a cover schedule for when any of us are off or not on service. Generally, there's 1 to 2 medical residents. These are your PGY 2s to 3s, 1 or 2 medical interns, 1 or 2 medical students. They could either be on their 3rd or 4th year, and then 1 or 2 pharmacy students on their 4th year rotation. A typical day, I always tell my students, I never tell them what time they have to be at the hospital. I just tell them what time they have to be ready by, because that may change depending on the student and their level of knowledge of internal medicine. The reason why I love internal medicine is the reason why students hate it. I love it because it could be any and everything. One day is cirrhosis, the next day is pneumonia. Of course, we have a whole lot of COVID now. And so students hate it. They want to be, they're not sure of their knowledge of what they do know, so they want to be kind of focused. And the most feedback, like the most consistent feedback I've received on my rotation is that it's challenging but fair. So I do try to be fair, and I do try to meet students where they are. They're going to come with some different knowledge base, different experiences. You know, there's some baseline things that they should know, but for the most part, I look at each individual student and I want to see them do better. I want to help close the gap for each one of them, and it changes depending on the student. So a typical day, pre-rounds are from 7 to 8:30 in general. Like, so students, honestly, they probably get there about 6 until probably, we have 5-week rotations. So till probably week 3, week 4, then they can kind of come in probably at 7. They generally come there at 6. I pre-round with them from 8:30 to 9:30 just to get the quick, I call it the quick and dirty. They worked up their patients. They've been assigned their teams. I have them work up their patients. So now we're going to go over those patients before we go on rounds, so that when the medical team gets to the patient's rooms, we've already worked them up. We already know what our recommendations are going to be. They run them by me, and we can become an active part of the rounding, and we're just not just there. So generally with the students, they have about 4 patients that they have to follow. I call it intimately, meaning they have to write a SOAP note for them every day. And then they have to do safety checks on the rest of the team. So if there's 14 patients on the team, the student's responsible for 4 of those patients. And then the other 10, they have to do the general safety checks. And what I call that are things that would affect, could potentially prolong a patient's stay in the hospital. So want to make sure that we've adjusted all the renal adjustments, hepatic adjustments. There's no drug interactions. We've separated out the medications that need to be taken on an empty stomach. We do assess DVT prophylaxis, stress ulcer prophylaxis, and nutrition and electrolyte repletion every single day. That is something that they have to do every single day because it changes. And rounds generally last about all of the morning, from 3 to 4 hours. So half the day they're rounding. And then after rounds, it depends on how long the rounds are. Because they generally have to do a lot of follow-ups. So we may have patients that's going to get discharged, so they have to go do discharge counseling. We may have new patients. We get new patients every 4 days on each team. So if they have new patients, then they have to do the medication reconciliation on those patients to make sure that we have all the medication they're taking at home. We may have a topic discussion or a quiz. Sometimes we'll end up, depending on how busy the service is, the team won't actually go over to pathology or radiology, where they don't actually want to talk to the radiologist or the pathologist, and we'll go with the team so that we can be in the room when they're talking about some of the imaging that may have some questions. And then of course, any meetings, so like journal club, patient case presentations, they do present their patients to me almost every day. And I call it running patients. We do run patients where they do the typical things that I always say you see on TV. They could say PM was I'll say I'm 25-year-old Black female admitted for pneumonia, that kind of thing. So, and the topics discussions, they range from hypertensive crises to acute decompensated heart failure, which I try to focus it more on acute care things. Even though HIV is my subspecialty, so HIV is one of the topics that we do discuss. Now, I will say this, one thing that I do have students do, I've created a pre-test for them that I tell them to take before they come to my rotation. I don't grade it. I tell them I don't even really look at it. It's for them. I encourage them to take this pre-test without using notes so they can kind of know where their gaps are. And I've created questions of things that they will probably see on my rotation. So it kind of gives them a gauge of where they are. And for some students, they do better than others. But I have gotten feedback that helped a lot, because it kind of helped reinforce some things that they felt like they knew, and then help pull out some things that they didn't, they realized they had forgotten. So it gives them a chance to review it before they come on my rotation. Here is just kind of a breakdown of some of the interventions we've done over the last couple of months. And again, this changes, percentages change. The highest percentage has been ADR identification. And that could either be to prevent it or something that happened that we may not know why patients say platelets are low, that kind of thing. The next highest is dose optimization. So again, we do, the patient has pneumonia, are they on, and they're on Levaquin, are they on the 750 or are they on the 500? And then again, I told you DVT prophylaxis, stress ulcer prophylaxis, and nutrition, and I should have electrolytes up there too, is the next highest, and then drug information and therapeutic monitoring. And then lastly would be the home medication reconciliations and discharge counseling would probably be the two lowest, only because, we don't do that every day. It just depends on when the patients are ready to get discharged. Lastly, I wanted to talk about some of the support that we provide for Atlanta Medical Center and Dr. Pound. So one of the great things, again, I do provide that clinical services for internal medicine for the physicians and the nurses. That's great. We also support research. The AMC supports my research, and I support whatever research they want to do. Right now, we're working on the impact of COVID-19 on medically underserved patients, because we see a lot of what we consider medically underserved as designated by our federal government. And we also working on Meds to Beds program and the effect of 30-day readmission. Transitions of care is kind of like my little passion. And that's going to be my focus probably from now until I retire or win the lottery. So, so any version of that. And also, so that leads me into what I want to do future. I've created a transitions of care elective, rotation elective, but I also want to create a didactic elective for transitions of care, and also a PGY1 rotation for transitions of care. On the right, you'll see some of the services that we provide. Again, we do staff development. Anytime there's a initiative or some education that's needed for the medical staff, pharmacy staff, or nursing staff. Well, I'll take that back. Nursing staff, we do let the residents and students do, but medical staff and pharmacy staff, one of the specialists will do it. Clinical service improvement, as Dr. Pounds try to expand clinical pharmacy services, we support her on whatever initiatives that she needs. And everyone does antimicrobial stewardship. We do support her PGY1 residency program. I precept all of the residents. Dr. Pounds has doubled our workload this year because she has increased her number from 2 to 4. So now we'll have 4 residents that we have to support, which gladly to do. And then we were in talks of starting a non-traditional PGY1 program. And Dr. Pounds, that might be interesting for you to talk about at the end.
Yes,
about
that's
that.
correct.
And then also there's always a question of financial benefit. So I like to think we save the hospital and health system some money, but it's all soft dollars. So, but I enjoy it. I am thankful to have a clinical pharmacy manager like Dr. Pound. She kind of, supports whatever it is that I want to do or we want to do. And it's because of her that I have gone to Nigeria 6 times. I'm sad COVID stopped us from going to 2020, and same thing for 2021. But I enjoy every time I go. Nigeria is a beautiful country. And also to brag, I've been to Jos, Lagos, Abuja, Benin City, Enugu. That's it. That's where I'm.
That's right. Yeah. Yeah.
Thank you, everyone, for your time.
Yeah. Thank you so much, Pam. That was great. Yeah. So we will move on to our next speaker. I'm not going to attempt to say your name, Angela.
Oh, not a problem, Dr. Pounds, but a pleasure. Thank you, Dr. Pounds, and a pleasure to get to be here today. I am Angelo Weisse, like Dr. Pounds.
Weisse.
You do a great job, Dr. Pounds.
Thank you. I appreciate that.
And, I was born and raised in Nigeria. I did have the opportunity to come here to continue my education, but I've always enjoyed going back. And I'm also thankful to Dr. Pounds for the opportunity to go back and do a couple of the programs and get to meet, a couple of you all as well. I had my PharmD training over in New York City at Long Island University. And then I went on to do my residency training in New York City at Kingsbrook Jewish Medical Center. Like Pam, I also love learning a bit about everything. And so I chose internal medicine as a specialty. And that's where I currently practice in that area as well as serve as a clinical faculty member over at Mercer University as well. So my practice site is Emory-Decatur Hospital. Like Atlanta, like Wellstar AMC, it is a community hospital, but it's about a 450 bed community hospital. Also has a level 3 neonatal unit. We see a general group of patients. So we see, different disease states and different ethnic groups. And we tend to serve our local community as well as have patients coming from different areas as well. We used to be called DCAB Medical Center, but we recently joined Emory Healthcare System. Emory Healthcare is one of the larger healthcare systems. They have a university teaching hospital. I guess if you think about it, like Ilorin University Teaching Hospital, but our hospital as a component of that healthcare system, we are a community hospital. And so how we're kind of similar and different from Wellstar AMC is we are a community hospital, but we don't have that medical residency program. And so we have some other graduate or postgraduate training programs, but not a medical residency program. So that, I think for us, our model can help others who may not have medical residents that are actively on site all the time, but maybe you still have some student learners that you could collaborate with as well. But we do have a podiatry surgery residency program, and we have a pharmacy residency program. We do have 4 PGY1 pharmacy residents. Our hospital offers a variety of medical services in addition to our adult medicine population. You know, we do heart and vascular care, cancer care. We have a women and infant services, as well as a weight loss center, among other programs. So that's just a little bit about the site. In terms of my service, rounding in a community hospital, our prior, you know, when we were at DCAP Medical Center, before we joined the larger Emory Healthcare system, we were able to have medical residents from, you know, a close by medical school, Morehouse School of Medicine. And we also were able to have medical students from the Caribbean medical schools. And so it provided a great opportunity for interprofessional collaboration. And so I was able to set up an interprofessional collaborative experience with our attending physician, with myself as the attending pharmacist, with medical students, medical residents, podiatry residents, as well as our pharmacy and medical students. And so we would round every day. It was mainly sit down rounds, but that was after the students had and the residents had already gone to see the patients, talk about the patients, collaborate on their care, and then kind of sit down and debrief and go over questions for the team, any recommendations we have for the team. When we migrated over to Emory's healthcare system, unfortunately, we lost some of the relationships with the medical residency program because Emory you know, wanted to more so have their, you know, their students and their residents. So currently we transitioned our service to working directly with the attending physicians and myself, along with our pharmacy students. And so we also have interprofessional rounds, you know, involving nurses and, you know, the clinical pharmacists, but we were also able to carve out some experience whereby we get to work directly with the, you know, with our students working directly with the physicians. So I'm just going to go over some of what we do and how that represents some of our interprofessional collaborative relationships that we have. And so like Pam, I have my students work up patients on the team. I have them focusing on certain patients. That way they get to know the patient, talk to the patient, evaluate all of the disease states that the patients have. I tell my students, even if your patient comes in for acute decompensated heart failure, but they have glaucoma, we also need to make sure that we continue their home medications. So we look at the well-rounded care of the patients. And so, you know, in addition to our students following up patients, we have them engage in activities from when the patient comes into the hospital to when the patient leaves the hospital. So some examples of what we do medication history and reconciliation. And so I have my students do med histories and med recs for all of the patients that they see on the team. And, you know, med history would involve asking the patients, what medications were you on at home? How did you take your medications? Did you have any problems taking your medications? Any concerns with your medications? Sometimes we have to call their outpatient pharmacies because imagine a patient being on multiple medications, having to remember the doses of the meds and how they take it. So sometimes we have to call the outpatient pharmacies. I know that might be different in Nigeria in terms of access or medication records in the outpatient pharmacies, but we sometimes do have to reach out to the outpatient pharmacies. Sometimes caregivers are the ones that have the list of the medications and know the medications, so we have to reach out to them. But just in terms of why that's important, the med histories would help us know what they were on at home so that we can know what we want to, what is safe to resume in the hospital. So we have that continuity of care because their hypertension doesn't go away because they're admitted for heart failure. Their diabetes doesn't go away. So we want to have that continuity of care. It also helps us establish if there are certain meds they were on at home that maybe they have a contraindication to continuing while they're inpatient. So we want to identify that. Maybe it caused their inpatient condition, maybe it's exacerbating their condition. So for example, just last week, you know, my student did a med rec on a patient who was admitted for a pulmonary embolism, so a clot in the lungs. And we found that she was on Xeljanz prior to admission for her rheumatoid arthritis. And Xeljanz has a black box warning for causing clots. And so the medication was ordered inpatient. So we had to circle back to the inpatient physician to say, these are the safety concerns, you know, we would recommend to hold off on it at this time. So that's another way we collaborated with the physician team in that regard. And then also we had to collaborate with their outpatient physician to say they do have rheumatoid arthritis. This is not safe at this time. we want to alert you so that you can make a treatment plan for when they get discharged, as to what they should use outpatient instead. So those are just some examples of ways we collaborate with the team. Typically, nurses are the healthcare personnel that primarily get med histories, but when we're on service, we help alleviate some of that from nurses and help with getting medication histories. Medication histories also helps us identify patients for patient education. And so I always tell my students, even if you have the perfect regimen for your patient, but your patient doesn't know why they should take it or how they should take it, your patient does not take their meds, then that's not effective. And so as we do med histories, we identify patients that we need to go back and educate on their meds. For example, we had a patient who came in for, to rule out a stroke. So she had concerns for a stroke and she had a prior history of a TIA. Upon history, she told us she was on aspirin, but she stopped it because she felt better and so no longer took it. And so again, that education with the importance of it, why it's indicated. We also help patients with access to their medications. So we have a couple of patients who do not have insurance. And so our hospital has a program whereby patients can get a free 30-day supply of their medications. And so we then collaborate with case managers and social workers to let them know, hey, this patient does not have insurance. Can you help set them up with that free 30-day supply? So we also do patient education and help patients with access to their meds as well. Some additional things that we do, which is probably more commonly what you all do on your end as well, is collaborating with the team to help review patients' medication regimens and help optimize their medication therapy. So again, we do that in several different ways, dosage optimization, appropriate therapies, contraindications to therapies, electrolyte replacements. And so we do that in several different ways for different disease states. Additional things we do as well is research projects to help optimize medication use and processes. And I typically mentor about 1 to 2 students each year on a longitudinal research project. And I don't just like to pick a project that I want to work on. I want to pick a project that, we've consulted with the pharmacy team, and that's something of interest to the institution. And also, especially with the physician team and other healthcare providers, what is of interest to you as well? And so one of the hospitalist physicians that we work closely with has a passion for transitions of care, which I share as well. And so we've worked with him the last few years in a couple of projects on transitions of care and have gotten to collaborate with nurses and quality assurance team members as well. It's also taken me a bit of outside my scope to working with NICU patients as well, collaborating on projects on neonatal hypoglycemia. And then we always think about, from a faculty member standpoint, kind of disseminating what we do. And so we also look to publish what we've done. And I've also collaborated with a few physicians on case reports on unique cases in our practice as well. As a pharmacy department, we provide several services. I just listed the ones that I get to provide alongside my students as well. And so we provide transitions of care service. And one of the physicians we work closely with is looking to set up a transitions of care clinic and has actually asked if students can help with providing that service. And so I think that's a good way to put pharmacy at the forefront of this important service. We also help with nursing and staff education. And like Dr. Pam had mentioned, we also serve in different committees as a pharmacy team in terms of antimicrobial stewardship. We also have a pharmacokinetic consult service. So those are just some ways in which we help to collaborate with the team. And I also just look for the last 2 months at our interventions and ways we've gotten to impact patient care. You know what, before that, I almost skipped over interprofessional education. So that's a huge passion of mine. I always keep this statement in mind: how do we want providers to work together if they don't learn together? And so it's important that we get them early learning together, whether that's on a student level or on a resident level, like Pam and Dr. Pounds had mentioned as well. But I've helped to foster and create an interprofessional education experience between our nursing students, physician, medical students, as well as pharmacy students as well. So that's another way in which we collaborate with the team. And then again, I'm thinking about research as a faculty member. And so I've gotten to do research and gotten to publish some of that work as well. So now just looking at the impact of what we've done over the last 2 months in terms of the service we provide, I also just collated the different types of interventions that we've done. See that, I guess for the last 2 months, again, this changes as well, but majority of our interventions have been that med history process and updates that are needed, avoiding therapeutic duplicates, counseling patients, that's a big focus of us as well, consulting on patients' medication therapy, as well as some therapeutic recommendations with dose changes, dose optimization, helping to make sure medications are safe and effective for patients. So that's a bit about what I do. It's always a joy to also incorporate students into the service that we provide and for them to make that transition from the classroom to the practice side and get to work collaboratively with the healthcare team. For me, it's always a joy when a student tells me, they had a conversation with a physician, they accepted their recommendation, and they could see the impact that it would make or it did make for their patients. And so we all have, we all can contribute to our students' learning and contribute to our patients' care. And it's always nice when we can incorporate student learners and resident learners as well. Thank you.
Thank you so much, Angela, for that great presentation, just like Pam. So I think we'll move on now to Dr. Ndefo.
All right. Good morning and afternoon to everyone.
Yes, hi, Uche.
All right, my name is Uche Ndefo, and I am from Anambra State. I've lived in the United States for a long time, but I like to come home, and I come home often, without COVID, of course.
Yeah.
Hopefully that is going away very soon. I've gotten both of my vaccinations, so I am excited and ready to go back to life as normal. A little about my background. I received my PharmD from University of South Carolina and did my pharmacy practice residency at Kaiser Permanente, Georgia region, which is in the Atlanta area. It was a managed care pharmacy practice residency. So I learned, I would say my residency was 50-50, where half of my rotations were based in managed care. Then the other half were typical experiences that a pharmacy resident would have. I'm also board certified in pharmacotherapy, and just sort of wanted to show you a little span, I guess, of my career. So right after my drug information residency, I stayed on at Kaiser Permanente in pharmacy informatics. And I'll explain what I did in each of those positions. And then I took a position as an assistant professor at Texas Southern University, where I have been for the past 13, almost 14 years. And I've sort of moved through the ranks, and my rotation site has also changed a little bit over the years. So when I finished my residency at Kaiser Permanente, I stayed on because that was the year that we transitioned to electronic medical records. So what I did was I helped build the content that went into the electronic medical record. So if you think about right now, or doing things by hand, when it transitions from doing it by hand to doing it online, there is content that needs to support the pharmacy staff. In other words, if let's say we have a formulary and the formulary has 2 statins on there, and on the market there are 8 different statins, part of that build requires trying to position those statins that are on the formulary to show up as the preferred agent when the prescribers go in to prescribe a statin. And if they choose one of the 6 that are not on the formulary, we created things called alternative messages, where it would say, hey, we prefer that you use this statin, but we happen to know that 20 milligrams of atorvastatin works as well as 40 milligrams of simvastatin. So here are options of what you can use that is on the formulary that we would prefer. So I did a lot of that content creation. And really, to be able to do that, you have to understand how the pharmacy works, how the pharmacy dispenses, and you also have to understand the clinical side of things. So that was what I did before I transitioned into academia. When I got to academia, my rotation site was at Harris Health Systems. Harris Health Systems is what we call a catch-all system. So whether you have insurance, whether you can afford it, if you need care, that's where you go in Houston. So there are 2 big hospitals that Harris Health System has, and then 18 different clinics. So the clinics are for our less acute patients, and then the hospitals are for our more acute patients, obviously. And we try to take care of these patients, both inpatient and outpatient. And what I did there was work as a drug information specialist. And working there, I had students from the school as well as residents who did a rotation with me in the Drug Information Center. We came up with cost-saving initiatives. Like I mentioned, this hospital is funded by county taxes. So we don't have a lot. Patients who are coming don't have a lot of money and are not really able to afford things that patients who have private insurance might be able to afford. So we look for a lot of different ways that we can save cost and save money and keep that pharmacy budget under control. So I did a lot of work with prior authorization, and with prior authorization, it just means that we prefer for a patient to have tried and failed things that are effective and safe, but cost less. So we come up with a lot of those cost-saving initiatives. If, let's say, there's something that is a brand and there is a generic that's on the market that's significantly cheaper, we try to funnel our prescribing to those cost-saving drugs. And if a patient did feel like, or if a provider felt like the patient needed something else, they would call, we'd go through the criteria with them, and then we would provide authorization to allow them to prescribe outside that established criteria. So there was a formulary management and pharmacoeconomics team that I worked with, and we did the work for the pharmacy and therapeutics committee, where we would review those things and create the criteria with the pharmacy staff and the medical staff so that everybody was able to contribute. When we did add things to the formulary or remove things from the formulary, or when something new came on the market, we would do things called medication utilization evaluations. And that was one way as an academician that I got a lot of my publications was, you know, after we would review those things, we would publish the results of what we've reviewed. And we would take it to pharmacy conferences and present it as posters. So I actually was able to do a lot of scholarly activity that was required for my rotation site. And for my academicians that are on the call, that's what you always want to be able to do, to really be able to succeed as in the world of pharmacy academia. Your rotation site you have to find a way to incorporate your research into your rotation site, because you're spending so much time on your rotation that for us, it's very difficult to be able to carve out rotation time and then carve out research time and then carve out time for your didactic teaching. So the most successful academicians I have seen are the ones who are able to publish what they do, as opposed to look for things to publish that are independent of what you're doing. From there, Harris Health actually developed a managed care plan. after the Affordable Care Act was passed, so that we could continue to provide for some of our patients who transitioned into affordable care, which is sort of a long story, but it is a government-funded insurance system. So when that happened, I transitioned back to managed care, which was my my training anyway. So it was very serendipitous for me to be able to go back to doing that. So I continued to do pretty much the exact same thing, except not really being able to completely manage it effectively within a health system, because with the Affordable Care Act, the patients could go anywhere. They didn't have to stay within our system. We didn't have as much control over them or over being able to control what was being prescribed. So we still continue to do the cost and utilization management, using formulary management strategies. Some of that the state of Texas actually required us to do certain things different ways. But I also got to continue to provide drug information responses and inquiries. And I did that up until September of last year, when I took a new position, which I now serve as the director of PharmD effectiveness for my school. And what that means is I do the work that is required for us to be accredited by the accrediting body for pharmacy programs. So I'm looking to ensure that our pharmaceutical scientists understand what is required of a pharmacist. So our pharmaceutical scientists would be, our medicinal chemists, our pharmacologists, our pharmacokineticists, but all those sciences, right? Those scientists do not practice as pharmacists. But at the end of the day, the information that they are giving and training these pharmacists on are preparing them to go out in the world and become a pharmacist. So we are wanting to make sure that everything that they are being taught is helping them become the professionals that we're training them to become. So with that role, I have transitioned to actually just taking students on what we call academic rotations. So the students come with me on campus and they help build and work on the different projects that we have to help with our pharmaceutical scientists. So in doing that, I have also been able to focus a little bit more time on my research. The active research projects that I have, one is looking at health disparities. So one thing that is a big problem for us here is that depending on your race, depending on your socioeconomic background, you're not as healthy as some other people. And I know that that is even true in Nigeria, right? People who don't have access to good healthcare, to the good hospitals, to the good doctors, their health is not as good as those of you that have that are able to afford the healthcare that you need. So we created a Center for Biomedical and Minority Health Research, and I am working as the Associate Director for Community Engagement. So we actually go out in the community and try to educate the community on health disparities and different things that we can do to try and bridge that gap so that there's not such a difference in health outcomes for people who can afford it and people who cannot afford it, because fundamentally we feel that healthcare should be a right and not a privilege. The other grant that I have that I'm working on is looking at aggressive prostate cancer in Black males. So, prostate cancer generally, when it occurs in our Caucasian counterparts, they don't die from it. They don't get the aggressive forms. They're able to get it under control, usually with just some oral chemotherapy. And that is not true with people that look like us. So we're looking to see what those factors might be, and if there's anything we can do to help that not be the truth anymore. So prostate cancer is one of those things that occurs more in us than it does, and the aggressive form especially. So we are looking into that. And then the third grant that I have is, it's really just a scholarship program that the students have to qualify for, and just managing that and being able to steward and be able to help our students afford pharmacy school. So I'm working on those things. And when I do have students right now, because my rotation has become academic, those students work with me on my grants, they work with me on my teaching, and they also work with me with the PharmD effectiveness role as well. So I still take students, they still come with me, and I train them on all the different aspects of things that I am working on with my administrative role. And with that, I'm going to turn it back over to Dr. Pounds.
Thank you so much, Uche, for sharing that with us. Great job. Now I'm going to hand it over to Dr. Ashish Advani. Ashish, you on?
Yeah, hi everyone again. It's great to see so many familiar faces. Joseph, you're doing God's work to moderate such a large call, and everyone else as well, that it's been a while, and so happy to see you all. You know, one thing Dr. Pounds didn't mention, and I just want to maybe touch on, she's really humble, so she would never say this, but I think you all probably recognize her as like a governor type, and we see her that way in what we do, and all of these stories that you've heard, like we really wouldn't be able to do any of these things, much like a good governor, like they free you up to go and do things, and all of our stories we really wouldn't be able to do without Dr. Pounds facilitating this for us. So she undersold hers quite a bit, and I just wanted to make sure that and I'm sure I speak for all of us when
thank you. Thank you.
So for me, Uche did a really great job to tell you a lot about drug information, so I won't repeat a lot of what she said. Oh, by the way, I don't know if you guys can see this. This is Benin City. This is my, last I was there, everyone else kind of shared their memories. So I'd be remiss if I didn't share the couple things that I miss. And I went to Lagos and Delta State and Benin City, and I don't play favorites, but you guys can see the picture here behind me is what I was thinking about this morning, of what I miss. And I miss the people, I miss all of you. You know, I used to teach here in America for 10 years, and nobody paid attention the way that people paid attention in Nigeria. There is a thirst for learning that I had never seen, and a really genuineness too. When people would ask me how I was doing, like people really cared how I was doing. And I would come back here and I would like not even know my neighbor. And it was just really weird. And so I really miss that. I miss the people the most. I miss goat pepper soup a lot. And I hope, like everyone else, that I get to see you guys in person soon. So for drug information, this idea that I had a while back is I've been pretty obsessed with how drug information is such a fundamental part of every clinical pharmacist job, and really being able to answer the questions in a way that helps people like truly understand the trade-offs between effectiveness and safety and cost effectiveness as well. And so I've always been pretty obsessed with like, how can we make it really easy for doctors and PAs and nurse practitioners and pharmacists to ask questions? And so we built this app to be able to do that, and people can submit their questions. And And one thing we learned as we've gone on here in the United States that I think may be helpful for you guys as well, because I believe that drug information is a fundamental part of what you do as well. And one thing I've realized is that a lot of people are asking similar questions across the United States. So we just took on our 5th health system, and every health system thinks that they have these unique needs. And really every health system has pretty similar needs. Now, Kaiser was probably different, like where Uche was, but generally speaking, our health systems are all pretty similar in the United States. And so, so a drug comes out and 1,000 different people are making a drug monograph, and 100,000 people are all answering similar drug information questions about that drug. And so, so what we're working on is more of like a centralized solution to be able to reduce a lot of redundant work that's happening in these silos in the United States. So, you know, I think about how you guys are in Nigeria, and I actually think that like such a service would work there as well. And it's just organizing it probably. But even if you didn't do anything, I just wanted to tell you that I think there's probably no better time to do clinical pharmacy and for drug information specifically. So I'll end with this is, you know, we just saw a really crazy year with COVID. March of 2020 was like probably our lowest point. And so thinking back now from March of 2021, like what a year it's been. And I think we'll look back in time and think it was pretty crazy, some of the things that we did, like some of the drugs that we used to treat COVID. You know, I don't know if this was the case in Nigeria, but here in America, hydroxychloroquine was protocol at every hospital around this time last year. And there was no evidence behind it, but it became a phenomenon for a good month. And looking back, I think we'll think that was pretty crazy that happened. Part of the reason that happened was sort of the panic of COVID, but that's not all of it. I think a big part of that reason is we have something called medRxiv now. And I'm not sure if you guys have heard of medRxiv, but basically anyone can publish any study now directly to people. So you can totally bypass the peer review system and publish your study in a minute to people. And this is the new world we live in. This I don't think we'll ever go back after this. I think medRxiv has fundamentally changed how studies will go out to people, and I don't think you can reverse from there. So so I think it's really important for us as pharmacists to be able to serve as those reviewers, like to help people understand the studies of, hey, hydroxychloroquine comes out, let's look at that study and be able to tell if it's a effective drug or not. And most people really have no idea, and they rely on us as pharmacists to be able to look at those studies and do that. And I think that's a huge opportunity for us in America, and also a huge opportunity for you guys in Nigeria. So that's all I had. And yeah, I'll turn it back over to you, Joseph or Dr. Pounds.
Okay, thank you so much, Ashish. So Joseph. Thank you. Is Joseph on? Thanks, Ashish, for sharing that innovative idea of what to do. So we'll wait on Joseph to take over from now.
All right, thank you very much. That was a wonderful session. So we're pretty much behind schedule. So we'll just take 5 questions or comments from participants. So you can use your raise hand icon, and I'll recognize you. It's comments and question time. comments, contributions, questions? Just from 5 participants, and we can close the meeting. Please. Okay, so if there are no questions or comments, then may I call on Pharmacist Ayetoro, if she's still online, to give the closing remarks. And thank you to our guest on the panel.
I would like to make a remark after she does.
All right, so I'll call Dr. Bello, the organizer of this program, to give the closing remarks. And thank you to our guests.
Okay, I think let's pause. What else to say? Okay, so I'd like to seize this opportunity to thank our guest speakers for honoring our invitation. We are indeed very grateful. We don't take this opportunity for granted. We know if you come to Nigeria, we know how much we will pay to have this opportunity. We are sincerely very grateful. And we thank all our participants, our lecturers, our HODs, our institution, the CMAC, Dr. Odega, for getting time to be part of this meeting. We are very grateful to everybody that partook in this very important clinical meeting. We have learned a lot very greatly. And by God's grace, we'll use all these things to improve our practice in the country. The slides and the videos of this presentation will be made available. Already it is live on YouTube, or we share it for everybody to benefit. We thank you all. So on to you, the moderator. Somebody is raising hand.
Right.
Yeah, thank you so much for the invitation, and just like everybody said, it's been a pleasure to be part of this. Just want to note a few things that maybe some takeaways that some people may want to think about. Some things that we heard over and over again from our presenters is residency program. All our clinical specialists, as you all noted, are all residency trained. So that may be something that could be something you all can think about as to what is happening in Nigeria, how do you want to go to the next level, and so on and so forth. Even for those who are already in practice and did not have the opportunity for residency, I think another thing to think about may be the non-traditional residency program. And that is a residency program that I will be starting here, I'm hoping like next year. And this is a residency program for people who are already practicing, seasoned practitioners that already have the experience but do not have the credential. And it can be done whereby they're still working, they're still making the same amount of money they're making, but instead of doing the residency program over 1 year, they're going to be doing it over 2 years. It's almost like learning while you work, so that's something that I would like to just throw out there for people to think about, and so on and so forth. There's a terminology you guys also heard from time to time, attending pharmacist. That's becoming like the buzzword here. And that happens on rounds. I think you all heard Dr. Pamela Moye-Dickerson say it, you all heard Dr. Angela say it. So attending rounds and involvement in interdisciplinary rounds, collaborating with other healthcare professionals. So I'm hoping some of the things that we mentioned here is something that will be beneficial that you guys can take home and then kind of see how it can be implemented if it has not been implemented. One thing that I also would like to share is all our speakers, with the exception of Dr. Ashish Advani, are faculty members. They are paid by institutions, pharmacy schools. one thing you heard over and over again is they have practice sites. Like Dr. Pamela Moyer has my site as a practice site. You heard Dr. Angela has practice site, but the uniqueness of what they do is that they are involved in what's going on in the pharmacy department in their practice sites. Like Dr. Moyer is one of my preceptors for my residency program. So how that's benefited me. As a clinical pharmacy manager, I'm the only specialist, actually two now. I just hired one for emergency department. So we have two specialists that is paid by my hospital. But I now have Dr. Moyer, I've had her for years as my internal medicine specialist, and we are not paying her salary, but we are getting services for her. So it's a give and take situation between my institution and the school. So that's another thing I want us to think about. How can we meaning directors of pharmacy or clinical pharmacy managers in the hospital, partner with pharmacy schools to move the clinical pharmacy practice forward? So I think, and then of course, you all heard from Dr. Ndefo, a lot of the innovative and creative things she's doing in her role in managed care, also involving pharmacy students in what she's doing administratively. So I just wanted to kind of share those last few things that I feel like, may be beneficial for our audience. Again, thank you all for the opportunity, and we hope for more future collaboration.
All right, thank you, Dr. Burns. We'll just take a comment from Professor Mbang and Pharmacist Precious. Professor Mbang?
Thank you very much. I want to sincerely thank our presenters, Doctors Teresa, Pamela, Angela, Uche, and Ashish, for giving us an insight, a good insight into what their typical days can be. Indeed, some of them, who is it that starts at 7:30 a.m.? Is it Pamela that starts at 7:30 a.m., a pre-round or whatever? It's amazing. I want to say that three major things stand out. And Teresa has mentioned some of them. You have one, the residency. Residency is one where we are still very much lacking behind. There should be residency, for the PharmD program. There should be residency for the fellowship, the West African Postgraduate College of Pharmacists, residency training, at those levels, apart from the clinical clerkship of the undergraduates going on normally. That is one. The second one, which she has explained, attending pharmacies, attending physicians, etc., etc. And the third one, which is the most important, is collaboration. There is so much collaboration right from the basis, right from the foundation, right from the student days. Pharmacy students, year 4, medical students, year 4, 3 and 4, having the rounds together, forming a team that with patients, with the maybe each team having about 14 patients or one person to 4 patients. We can see that collaboration, being trained together, understanding each other, knowing each other, respecting each other, and also knowing and accepting the worth of each other's profession and areas of specialty. That's where we have to go back to the drawing board in Nigeria. We need to do that and do it very fast for the next generation, for the next dispensation, so that we can have peace, harmony, and collaboration in the health sector in Nigeria. I pray our leaders in the hospitals, in the various institutions, and also in the academia will rise up to this occasion and ensure that Nigeria The health sector, Nigeria, care sector in Nigeria is the same all over, and especially in the US. Thank you very much. It's wonderful to see you all, and congratulations for your. I pray you have a wonderful time. Heaven on earth. We hope to see you when COVID is.
That's right. Thank you. Thank you so much. Thank you. Yeah, I'm pleased. I want to encourage everybody on you all have our information on WhatsApp if you want to, because I see a couple of chats. Feel free to connect with us on WhatsApp. Please feel free to give them our contact information. I see there's somebody interested in non-traditional residency program. Anything we can do going forward, we're willing to help. And Ashish, again, I forgot to thank you for really putting PharmDs. If you all notice, as PharmD, we can do everything. What Ashish did is that he did something very innovative with his clinical background. He's the president and CEO of PharmD. Doesn't mean we can't do this in Nigeria. So please see how we can work together to continue to support each other. So thank you again.
Thank you. And finally, we take Precious. Pharmacist Precious, please.
Yes, thank you very much. Can you hear me, please?
Yeah.
Okay. I listened keenly to the speakers as they were going. I was very impressed with their presentations, and thank you very much, Dr. Pounds.
Oh, you're welcome.
Thank you very much as well. There is one thing I noticed that the faculties that are in the hospital, I find the way they keep records of their interventions in a particular period. Okay, we did 50% of what we do was into medication reconciliation, 30% was this and that. I find that it's actually missing from my short stay when I was in my internship program in a hospital. Yeah, I hope colleagues who are in the hospital would see that and try to improve on that record keeping aspect. My specific question, this goes to actually all those that spoke well, was if in their programs, especially Dr. Uche, if they have scholarship opportunities for young pharmacists that are still in their early career phases that are hoping to explore, possibly go outside of the shore of the country to get into any of the programs there, then see what they can make out of their career generally. Thank you.
Dr. Uche, Ndefo.
So, my advice when people ask whether they should come to the States to further their career, I actually don't encourage it because it is so much more expensive than going to school in Nigeria. Once you are a licensed pharmacist, you can always test to become a pharmacist here, but it'll cost you a lot less. So a lot of the scholarships and the programs that are available in the States usually require that you are a citizen. So it's very hard to find those programs for non-citizens. But once you are a pharmacist, the United States recognizes you as a pharmacist. You just have to take a test to show that it's equivalent. And when you pass that test, you'll do some internship hours, and then you become a licensed pharmacist here. So that is the most cost-effective way if you're looking to transition out of Nigeria to the United States. But unfortunately, I just don't recommend coming to school here just for the cost. And you guys can weigh in and say whether this is an accurate assessment. But for me, money-wise, it ends up just being cost prohibitive for a lot of people to pay for school in dollars.
Yeah, thanks, Uche. And I think I will agree with Uche that it is definitely more cost effective to get at least get your first degree, your Bachelor of Science in Nigeria. Then you can come here and do the test, start practicing here, then you'll be able to go. So I will agree with her. I'm not saying that we haven't had people in the past who have done it, but the cost, there's a huge cost difference. The average amount for a year now for pharmacy school is, I mean, I know with Mercer University and Pamela and Angela, correct me if I'm wrong, is at least 30,000 plus, if I'm not mistaken. Am I correct?
Yeah, it's about 32,
Yeah.
about 32,000.
That's right. You know, so it's definitely, it makes more sense to at least do it in Nigeria. Yeah. Okay. Thank you.
Thank you, Ma.
Thank you. Thank you. You'll have a good day.
Honors.
Bye-bye. Okay. Bye-bye.
Yeah. Bye-bye.
Thank you, everybody.